So we shall now go on to our next speaker, Dr. Jeevan TITIYAL, one of the leaders of ophthalmology of our country, with many firsts to his name, very many awards and accolades, heading the RP Center with an extreme dynamism and terrific skill sets. And we are all going to watch how wonderfully things are going to evolve in his tenure. And we look forward to your talk, Dr. TITIYAL, intraoperative OCT and its utility in cataract surgery.
Yeah, thank you, Chitra, for the invitation, and I appreciate ARC team putting so much effort in disseminating knowledge across the entire ophthalmic fraternity. I think we did have discussions on various aspects of modernizing the cataract surgery to improve your outcomes. So this might talk, though I have spoken in many forums before also. This is like taking your clinical investigations onto your OR, especially the entry segment OCT. And if you have something better, which gives you so much detail on the table, nothing will be better than that. So this is what I think, potentially what all areas where we can have advantage of intraop OCT, which are attached to some of the microscopes to give you actual visibility. In a routine cataract surgery, which Arul talked about, looking into incisions, the hydro procedure, and intraocular lens positioning, there are three critical points where this will help us to judge how effective your surgery was on the table actually during your steps and subsequently after completion also. Then most importantly is the challenging cases where it has a great role in actually doing a on-table assessment, and also tells you what is the dynamicity of each step of your surgery on these difficult cases like wide cataracts, hard cataracts, posterior polar cataracts, subluxation cataracts. It does have its impact in improving your surgery. Then other part which may not be cataract but phakic intraocular lenses has a great role where we can assess the intraoperative ball, which may be sometimes beyond your imagination to very shallow to very, very steep ball, or sometimes the lens may be inverted, inverse. That can be real help. So we could publish the entire gamut of use of anti-segment OCT in anti-segment surgery also, right from the ocular surface surgery to the cataract surgery, cornea surgery as such. So just let me take you through various aspects. The first thing I would like to delineate is incision quality type, which Arul talked about, making it absolutely square shaped. Another important consideration would be what is the planarity of your incision. Uniplanar, biplanar, triplanar, which we talk about. And most importantly, the distortion which can happen during your surgical procedure of this incision, can it be checked up? That is also important. And the damage which can occur to your incision can also be seen. If you see here, this is the uniplanar incision, you can see very clearly. This is a triplanar incision in a manual blade incision. This is a femtosecond giving a very nice triplanar incision. And the impact of this incision we have seen with IOCT examination, where we found that manual incision versus femtosecond incision and the DMD associated near the wound site is very important to see. This is a post-op anti-segment OCT images also with that. We realized that if you do a nice orientation of incision with femtosecond, the chances of a wound site DMD is less with the femtosecond incisions. The second important aspect would be to see what type of hydro procedure we have done in these cases, which normally we clinically talk about the upward shift of a lens diaphragm, a fluid wave, but it's very difficult to see if you have achieved the cortical cleaving hydrodissection. If you see here very classically, we know that in the posterior capsule is clean, there's a space, and the epicortical cushion is also detached from there. So this is the actual cortical cleaving hydrodissection which we have achieved here. This is, you can see, epicortical cushion. This is a space which we have created, and this will be decompressed as soon as you make a compression through your needle in these cases. So this is what I am talking about, incision, the distortion which can happen after completion of phaco or after insertion of IOL can be seen in 3-dimensionally. People measure 2-dimensionally with various devices. but the distortion three-dimensionally can be measured by IOCT attachment. This is the tilt and position lens can be judged with these. Other area we talked about the difficult case scenarios like a white cataract, where we could classify the white cataracts on the table based on images which we could pick up. So these are various range of images which can be picked up, spectrum of white cataracts, which we deal with routinely in all difficult cases. So this is a type 1 where you have a regularly arranged lamellar cortical fibers and minimal intralenticular clefts. So this is a simple case where you can do a nice capsulorhexis without fearing the rhexis getting extended into periphery, like this case is a type 2 variety where you have multiple sheets of a cortical hydrated fibers and clefts which are intermingled between the hydrated sheets and very less fluid in these cases. So as soon as you make a nick, you have an the cortical sheet bulge out like a mountain, and this jeopardizes your rhexis going to periphery very, very soon in these cases if you don't make appropriate steps. If you see this video here, as you make a small nick here, you can see that there's no fluid will come out in these cases. The fluid is in between the fibers. The entire fiber raises the mountain and puts a pressure on the periphery. If you don't have a visco compression in periphery, difficult to make a small rhexis here, decompress the pressure from inside with bimanual aspiration. Needle decompression may not work in such cases. So you can see after decompression, entire bulge becomes convex and rhexis can be completed very, very effectively in these cases. Type 3 has a combination. You have a hydrated sheets and you have a multiple pockets, but you can see they have already broken the sheet. So these cases, needle aspiration might work, and you can also do a routine surgery in these cases without fearing any difficulties. And type 4 is routine, cases where going towards a hypermaturity. Entire thing is a fluid which is milky. And if you puncture, the milk comes out and your pressure goes down and surgery becomes very simple in these cases. Now, I would say IOCT is a real help in improving your surgical technique. The change which can you do during your procedure of rhexis is very, very important. 2-stage versus single stage. Needle aspiration versus bimanual aspiration or a punch people talk about can be assessed by IOCT. Second aspect is a posterior polar cataract. Those can be assessed. So you can see here, this is a totally defective opening in the posterior capsule in a congenital case. These are other varieties where you have an intact posterior capsule. They can also be classified depending on the morphology of cataract. This is what you can assess the entire posterior capsule. This is type 1. Type 2, where you can't assess the pole, but periphery, you can see the posterior capsule. So these cases you still may have an intact posterior capsule. This is type 3, where entire range of a posterior capsule cannot be picked up by your OCT because there's a shadow and this posterior polar disc is very, very thick. So you have high chances of posterior capsular rupture happening in these cases. So type 1, we do hydrodissection and hydrodelineation both for a safety. And type 2, type 3, where we don't do hydrodissection, we do just hydrodelineation. And that is decided by the picture you see on the table. You can see that the completion of surgery, intact posterior capsule in these cases. Type 2, type 3, we don't do dissection, only delineation. You can see multiple delineation we can do in these cases. And subsequently, you can complete the surgery. The IOCT will also tell you that if your posterior capsule is intact or not towards the end of your emulsification. Like you can see here, we have done a complete nucleus emulsification. This is epicortex. And the thickness of epicortex also tells you that PC is intact. You can see this is a PC intact in this patient. This is a sign which will describe the posterior polar cortical disc defect, which is very, very common in a posterior polar cataract. This is what video we sent to APACRS. We got a best cataract session film award this year. And right, also from AIOS, we got a best session award in this particular case. To summarize IOCT, as I told you, this takes your clinical investigation like anti-segmental OCT to operation theater, makes you feel better, make you see better, and make you perform the surgery better to have improved outcomes. So you can assess the various types of cataract, classify them to your surgical analysis wise. You can also look into a risk of PCR or a rhexis extension.
So 1 minute remaining.
Defect. And the incision architect, which is so important to improve your surgery on the table, also decrease the complication happening in the post-op period, is also very, very important analysis with IOCT, especially the desmoid membrane detachment, which can occur in difficult cases like a Fuchs cases. If you don't see them, then the desmoid detachment can enlarge and become a totally hazy cornea next day. So this is what we talked about. We have Artibo 800 for last 2 years, and this gives you a real good view of surgeries, especially OCT is so clearly visible now. You don't have to see the OCT through microscope, which is sometimes difficult. The screen gives you so much of big picture. It tells you everything in a great detail, and it's a great teaching tool for teaching institutions. In a COVID time also, all people can be sitting almost 2 meters away from your surgical field and have the same feeling what a surgeon does. So this has a future, and I am pretty sure future microscope will have attachment like this, where you have a heads-up surgery done in the 3D manner. Thank you, and I wish you all the best for the future, and see from a distance and better and bigger and more magnified, more clarity of your surgery. Thank you, Chitra, for invitation. You are muted, Chitra.
How this would coexist with the 3D visualizing systems. So you've answered that. But for a general ophthalmologist, how wrong are you if you just rely on the ASOCT for assessing the PC integrity, excepting for the fact that the ASOCT you can get some false negatives and that IOCT is real time. But in majority of the situations, I think you are okay with
you're absolutely correct, Chitra. You can clearly assess these cataracts on anti-segment OCT, and the same picture is seen in the IOCT also. So this is now we talked about posterior segment OCT. We talked about topographies. Anti-segment OCT is also a significant tool, has to be there with the cataract workup now, especially for cases with posterior polar wide cataracts. It is important. Cases where you have done a vitrectomy, other things, it is really important tool for all of us, and it should be there. The only thing which may not give anti-segment OCT is what happens once you make a particular step. I make a nick on the anterior capsule. I can't assess that in the anti-segment OCT. It gives you just that, okay, this might happen. But what happens on the table, that is picked up by IOCT.
Do you think the future, with so much information about the capsular bag dimension and all, which is available with IOCT, it will bring in a greater nuance in IOL power calculations in future?
Definitely. I'm already on into this work, because after we implant the IOL, we remove the viscoelastic. And once we start hydrating the main wound and side port, you can see the distension of a capsular bag and the little movement of lens, especially if the lens is not fitting into a capsular bag. Especially if I use a Technist lens, the lens moves from this capsular bag. And we are just titrating the various types of cases, and we'll correlate with the measurement of IOL master 700, which is the lens thickness, the volume. So we are trying to correlate with the capsular bag position is going to similar. So we are having IOCT videos and trying to assess them, correlate with the pre-op assessment, and try to come out with some algorithm.
Thank you very much, Dr. TITIYAL. Always, it's a treat to